Hello, friends. Welcome to Creative Medicine. In this lecture, we will learn about
Aspiration. Aspiration is a preventable cause of hypoxia. Aspiration occurs in 1 in 3,000 people, and the mortality rate of aspiration is 5 to 70%. Predisposing factors of aspiration. Aspiration can occur in full stomach or in decreased lower esophageal sphincter pressure like pregnancy, for example Mendelssohn syndrome, or increased intra-abdominal pressure. So aspiration might occur whenever there is delayed gastric emptying or whenever there is nasogastric tube issues. So in all these conditions, aspiration can occur. Risk factors of aspiration. Whenever the volume is more than or equal to 25 ml, or if pH is less than 2.5 and solid particles are present inside in the stomach, then there is increased risk of aspiration is seen. So diagnosis of aspiration can be done under general anesthesia, mainly by the hypoxia. Prevention of aspiration. For prevention of aspiration, we should advise the patients to do nil orally. Solids should be given within 6 hours. Fatty non-vegetable foods should be given within 8 hours. Clear fluids should be given in 2 hours. And nil orally. Solids should be given 8 hours before the surgery. This means solids should be given 6 hours before the surgery. Fatty non-vegetable food should be given 8 hours before the surgery. Clear fluids should be given 2 hours before the surgery, and breast milk to be given 4 hours before the surgery. Anesthetic management of high risk of aspiration. If there is high risk of aspiration, then anesthesia of choice is regional anesthesia. General anesthesia can be given. After general anesthesia, we should give rapid sequence induction should be given. Pre-medication. In the pre-medication, we have to give metoclopramide and acid secretion preventing or neutralizing things should be given. So metoclopramide will increase the lower esophageal sphincter pressure. Then induction of anesthesia. Induction of anesthesia include ketamine. Ketamine maximally it preserves the airway reflexes. Suxamethonium or rocuronium can also be given. First induction we give ketamine because it preserves the airway reflexes, followed by suxamethonium and rocuronium is given for has neuromuscular blockers. Bag and mask ventilation is absolutely contraindicated in case of aspiration. Cricoid pressure can be given especially by Selleck's maneuver. After giving cricoid pressure, we can intubate the patient and we can inflate the cuff. Modified Selleck's maneuver. In modified Selleck's maneuver is a gentle positive pressure ventilation of less than 20 centimeters of water with cricoid pressure. Modified Selleck's maneuver is done when delayed intubation is expected. Then you do modified Selleck's maneuver. Indications for recent sequence indication for rapid sequencing of intubation or contraindications for bag and mask ventilation. Contraindications for bag and mask ventilation and indications for rapid sequence induction include full stomach, pregnancy, intestinal obstruction, if the patient has obesity, mainly abdominal obesity, if the patient has abdominal tumors, ascites, where there is increased intra-abdominal pressure, diabetes leading to gastroparesis, or hiatus hernia or neuromuscular disease, hiatus hernia where there is decrease in lower esophageal sphincter pressure, or in cases of neonatal surgical emergencies like diaphragmatic hernia, tracheoesophageal fistula, meconium aspiration syndrome, and pyloric stenosis. All these are indications for rapid sequence intubation or these are contraindications for bag and mask ventilation.
Summary. Aspiration is a preventable cause of hypoxia. It is seen in 1 in 3,000 individuals. Mortality rate of aspiration is 5 to 70%. Predisposing factors are in full stomach, or decreased lower esophageal sphincter pressure like in pregnancy, or increased intra-abdominal pressure, delayed gastric emptying, and nasogastric tube. Other predisposing factors. Risk factors are if the volume is more than or equal to 25 ml, or if the pH is less than 2.5, or if there is solid particles are present in the stomach, it is a risk factor. Diagnosis is done by general anesthesia by the hypoxia. Prevention is by nil per oral. We should not give solid fluid. Foods are given before 6 hours. The patient should be nil per oral for solid foods for 6 hours, nil per oral for fatty non-vegetative foods for 8 hours, nil per oral for clear fluids for 2 hours, nil per oral for breast milk for 4 hours. Then uh, Then anesthetic management of high risk aspiration. Anesthesia of choice is regional anesthesia. General anesthesia can be done by rapid sequence induction. Metoclopramide is given as pre-medication to decrease the tone of the lower esophageal sphincter pressure. Similarly, acid secreting or acid neutralizing drugs are also given. Induction is done by ketamine, which preserves the airway reflexes, and this ketamine is followed by, we can give succinylcholine or rocuronium. Bag and mask ventilation is contraindicated absolutely. Salix maneuver is done, that is, a cricoid pressure is given in order to intubate properly and to inflate the cuff. We give cricoid pressure, which is called a Salix maneuver. We also have a modified Salix maneuver where we give gentle positive pressure ventilation is given to the patient along with cricoid pressure, so that the pressure will be less than 20 centimeters of water. It is only done if there is delayed intubation is suspected. Indications for rapid sequence induction or rapid sequence intubation or contraindication of bag and mask ventilation are full stomach, pregnancy, intestinal obstruction, obesity, abdominal tumors, abdominal ascites, diabetes mellitus, gastroparesis, hiatus hernia, neuromuscular disease, diaphragmatic hernia, and other disorders like tracheoesophageal fistula, meconium aspiration syndrome, and pyloric stenosis.
Thank you and thank you for watching.